Okay, ladies and gentlemen, here we go. First lecture with slides that I feel look so much better. Now, first and foremost, let me go ahead and preface this. I know I had said that I was going to redo all of the slides because they were ugly and black and white. And you know what? They are. And I'm not a big fan of them. And they bore you and lull you to death. So what I am going to do, because after thinking about it, I thought, okay, well, if I were you, I would want to have these slides so that I can print out a copy of them. And then I would want really nice slides in a pre-recorded lecture so I can keep from passing out, to be fair. I know it sounds terrible, but been there, done that, still doing that, got the t-shirt, and it's a size large, let's be fair. So that being said, I would prefer it if you grabbed all your slides, had them printed out, ready to go, so you can throw notes on top of them, because I'm going to go over a lot of information. Inflammation and healing is no joke. We get into a lot of functions, primary, secondary, tertiary functions, and if that weren't worse enough, you have a little cute kid who is singing in the background while I'm trying to talk over this, and Ms. Rachel, who is trying to calm my small child down with her active love of song. So buckle up. So sorry, guys. I am super appreciative that you're working through all of this with me, and I hope this works out. I hope you guys feel good in this. I hope this is a good supplemental video along with your readings that you're going to do that's going to give you like a quick overview of the pathophysiology that we may or may not have forgotten, disease processes, who these players are in this whole cell-mediated response, what they mean, and hopefully we will be able to directly correlate that with questions on our exam, which I'm supposed to be finding out in the next couple of days. How that test making strategy and how that structure looks. So I will give you more videos as I have information to give you. So try to take a deep breath. This is a lot. This is the first recording we're going to go through. Yay! I'm so glad that one person's happy at least. Unfortunately, her frontal lobe development is lacking, so you big boys and girls are going to have to tell me how this really goes. So yeah, get some popcorn, get a Coke. Don't forget, play these recordings at night while you're sleeping. I know that sounds super creepy, but it works for your long-term processing of this information, and it's going to be so much easier for you to kind of have it jump into your brain via osmosis, if you will. So yeah, let's get going and get started, and hopefully this does some good for you guys. Okay, so inflammatory response. What are we going to learn about? So we're going to learn about how to describe the concept of self-tolerance. I'm going to teach you how to explain the differences between the inflammation and immunity in terms of cells, function, and features. We're going to use the knowledge of pathophysiology to describe the basis for the 5 cardinal manifestations of inflammation. Ooh, sounds so mystical and magical. We're going to discuss the influences of aging processes on inflammation and immunity and how these changes increase health risks for older adults. I want to make sure you guys are able to interpret a white blood cell count with differential to indicate no immune problems, immunosuppression, infection, or an allergic reaction. I'm also going to make sure you guys understand how to differentiate the protection provided by active immunity, passive immunity, and cell-mediated immunity. And I also want you to describe the expected immune system responses to the presence of transplanted organs and the need for drug therapy to prevent any type of transplantation reaction. All right, so inflammatory responses in the immune system work with other defenses to provide protection from harmful microorganisms and cells. We all know that. As indicated in your reading, the definition and the concept of protection, the cell products of inflammation and immunity are represented mostly by like knights and soldiers behind castle walls. And I want you guys to keep this in mind because you have to have a foundation for all of this. And the best way to do it is through association. So I am going to talk a lot of association so that you understand how to look at these specifically, because if you kind of think of them as cartoon characters factors, they kind of become ever present and, dare I say, real in your framework and conceptualization of how all of this kind of follows along. So if you need to draw little random pictures on your slides, I think that's a smart idea. Go do that. And I'm going to explain what these things specifically mean. So the products made by cells like cytokines, growth factors, and antibodies, they're more like the weapons of the knights and the soldiers. So try to keep that in mind. Additionally, they serve as watchers and alarm systems actually within the castle walls, and that would be considered like your skin and your mucous membranes. They also help maintain and repair the walls when damages occur. So think about that for a second. Try to figure out how that works best in your brain and either draw it out, write it out, rewind it, do whatever you need to do. Remember, infectious diseases are common. Most people, however, are healthy more than they're sick. So inflammation and immunity, those are major defenses that protect against disease when the body has invasion by any organism. Those same defenses also help the body to recover after tissue damage. So for that reason, inflammation and immunity are critical to maintaining health and preventing disease. When all the different parts and functions of inflammation and immunity are working well, the person's considered immunocompetent and has maximum protection against infection. However, immune function is reduced by many diseases, injuries, and medical therapies, as we all know. Reduction of immune function may be temporary or permanent, but it always endangers the patient's health. And that's all I want you to really do is keep that in the mind, in the back of your mind if you can. And I'm going to take a sip of soda so that I don't stumble over my words any more than I am. Oh, that's delightful. Good stuff. All right. Other problems that occur when immunity overfunctions or functions in appropriate times, at which the time is normally protective response, and then becomes an enemy. So we'll talk about that as well. And it's usually related from excess or inappropriate inflammatory or immune responses. So immunity is composed of many cell functions that protect people against the effects of injury or invasion. People interact with many other living organisms in the environment. It is what it is. The size of these organisms varies from large, so like other humans and animals, to microscopic, which would be our bacteria, viruses, mold, spores, pollens, protozoa, cells from other people or animals, and a partridge in a pear tree. I mean, it is what it is. As long as the organisms do not enter the body, they pose no health threat, to be fair. The body has some defenses to prevent microorganisms from entering, such as intact skin and mucous membranes, skin surface of the normal flora, natural chemicals that inhibit bacterial growth, and so on. These defenses are not perfect, as most things are, and the invasion of the body by organism often occurs. It is what it is. Invasions occur much more often than does an actual disease or illness because of proper immune functioning. So the purpose of inflammation and immunity is to provide protection by neutralizing, eliminating, or destroying organisms that invade the internal environment. So to protect without harming the body, immune system cells use protective actions only against non-self proteins and cells. So let me say that one more time. Immune system cells use protective actions only against non-self proteins and cells. So this is where we get into a little bit of gray area, but we'll get into it. So immune system cells can distinguish between the body's own health self cells and other non-self proteins and cells. So what exactly are we talking about here? Self versus non-self cells. What does that mean? So non-self proteins and cells include infected body cells, cancer cells, cells from other people, and invading organisms. Recognizing self versus non-self, which is necessary to prevent a healthy body or to prevent healthy body cells from beginning to destroy along the invaders, is called self-tolerance. So the immune system cells are the only cells capable of determining self from non-self. Let me say that one more time. The immune system cells are the only cells capable of determining self from non-self. And that's really important because self-tolerance is possible because of the different proteins present in each cell membrane. Now, Each cell is surrounded by a plasma membrane with different proteins protruding throughout the surface. So, for example, in liver cells, many different protein types. All right, let me just wait for this to be done. Sorry, guys. Thank you, avocado guitar. Okay, now, where was I? So, yeah, each cell is surrounded by plasma membrane, which we just talked about. Liver cells, cell protein types are present on the cell membrane surface, and the amino sequence of each of these protein types differs from that of other protein types. So, some of these proteins are found in the liver cells of all animals, including humans, that have livers, because these protein types are specific to the liver and serve as a marker for liver tissues. So other protein types are found only in liver cells of humans because these protein types are specific markers for human tissues. So keep that in mind. And additionally, each person's liver cells have surface proteins that are specific to that person. So there are ones that we share, there are ones that are concomitant with other species of liver cells, and then those are those that are just specific to ours based off of pure genetics. So these unique proteins would be identical only to the proteins of an identical sibling, and this is, again, because of genetic coding. These unique proteins are known as human leukocyte antigens, or HLAs, human leukocyte antigens, or HLAs, and they're found on the surface of all body cells of that person and serve as a universal product code or a cellular fingerprint or a UPC code, anything that's going to be a discernible identifier or VIN number on a vehicle for that person. One person's human leukocyte antigens, or HLAs, are recognized as foreign or non-self surface proteins, are non-self to another person's immune system. They are antigens, which are proteins capable of stimulating an immune response. Okay, so everyone's favorite diagram, one that has 15 different players and one little blurb about it, and that's supposed to be your way of recalling all of this, which is not going to work. So, cell injury, just remember there's a vascular response, there's a cellular response, and here's where we get into the craziness that are the neutrophils, the monocytes, the neutrophils, the monocytes, lymphocytes, macrophages, phagocytosis, and the action of tissue macrophages, immune response, as well as the process of cell death and injury and how that is applicable to the vascular response and what happens during that process. So let's back up the train here just a little bit and let's introduce these guys, if we can, over here to the right. So if the variable or the action is inflammation, your buddies are going to be your neutrophils, your macrophages, your monocytes, your eosinophils, and your basophils. I'm going to say that a little bit slower. So your neutrophils, your macrophages, your monocytes, your eosinophils, and your basophils. So what the heck does that all mean? So just know that the function of a neutrophil for right this second is a non-specific ingestion and phagocytosis of microorganisms and foreign protein. Oh yeah, that's super easy to understand and acknowledge, right? No problem. Your monocytes, those guys are the destruction of bacteria and cellular debris that matures into a macrophage. And a macrophage is a nonspecific recognition of foreign proteins and microorganisms, and ingestion and phagocytosis. Your basophils are the guys that release the histamine and heparin in areas of tissue damage. So they all have their little pieces and parts and players in this whole situation, and I'm going to get into all of it, so just take a deep breath. We're going to start with our neutrophils, and we're going to keep moving along as we go from piece and part to piece and part. So neutrophils are mature neutrophils, specifically, make up between 55% and 70% of the normal total white blood cell count that you have. Neutrophils, wow, I can really talk today. Neutrophils come from the stem cells and complete the maturation process of the bone marrow. They're also called granulocytes because of the large number of granules present in each cell, so that might be easy to remember. Other names for neutrophils are based on their appearance and their maturity. Mature neutrophils are also called segmented neutrophils, or what they call SIGs. Polymorphonuclear cells, or what they call the polys, or the PMNs. M is in Mary, N is in Nancy, because of their segmented nucleus. Less mature neutrophils are called band neutrophils, or bands, or stabs, because of their nuclear shape. Am I going to expect you to remember this for the purposes of an exam? I'm going to need for you to know the simple stuff. I'm not going to need for you to necessarily know that polymorphonuclear cells are called polys. That's silly. I'm not going to ever make you do that. But for the purposes of making it easier for you to remember, that might be beneficial. Take it if it resonates. So usually the growth of a stem cell into a mature neutrophil requires about 12 to 14 days. This time is shortened by the presence of specific growth factors like cytokines, such as granulocytes, macrophage colony stimulating factors, and granulocyte colony stimulating factors. The purpose and the action of the cytokines are basically, they're described in your book, which might be a little bit easier for you to kind of look and read along, but I'll get into the purpose of the cytokines here in just a second. I'm trying to take this as easy as possible, and I can literally feel the tension, and no one's even watched the slide yet, so that's not a good indicator. In the immunocompetent healthy person, more than 100 billion fresh mature neutrophils are released from the bone marrow into circulation on a daily basis. That's pretty amazing. The huge production is needed because the lifespan of each neutrophil is about 12 to 18 hours. So try to keep that in mind. Neutrophil function provides protection after invaders, specifically bacteria, enter the body. So although the neutrophils are the largest group of circulating leukocytes, each cell is relatively small. This powerful army destroys invaders by phagocytosis, which is munching down on some grindage, and enzymatic digestion, although each cell is small and can take part in only one episode of phagocytosis at a time. Mature neutrophils are the only stage of the cell that's capable of phagocytosis because the cell is responsible for continuous, instant, nonspecific protection against organisms. The percentage and actual number of mature circulating neutrophils are used to measure a patient's risk for infection. The higher the number, the greater the resistance to infection. So this measurement is called the absolute neutrophil count, or the ANC. It's Abby, Nicole, Charlie, ANC. Also called absolute granulocyte count or total granulocyte count. So try to keep that in mind. Put an arrow next to it, whatever works best for you. Now, the differential of a normal white blood cell count shows the number and percent of the different types of circulating leukocytes. So usually most neutrophils released into the blood from the bone marrow are segmented neutrophils. Only a small percentage are the band neutrophils. Less mature neutrophil forms should not be in the blood. Such problems such as sepsis cause neutrophils in the blood to change from being mostly segmented neutrophils to being less mature forms, which is a big problem. So this situation is termed a left shift or bandemia of a left shift because the segmented neutrophil, which is seen at the far right of the neutrophil pathway, is no longer the most numerous type of circulating neutrophils. Rather, more of the circulating cells are bands, the less mature cell types found farther left on the neutrophil pathway. A left shift indicates that the patient's bone marrow cannot produce enough mature neutrophils to keep pace with the continuing infection and is releasing immature neutrophils into the blood. So unfortunately, most of these immature cells are of no benefit because they're not capable of phagocytosis. So what the heck do I need to remember out of all of this? Remember your absolute neutrophil count remember that it's also called a granulocyte count or total granulocyte count. Make sure that you understand what it's for, and make sure that you understand what a left shift indicates, which is that a patient's bone marrow can't produce enough mature neutrophils to keep pace with everything, because they aren't capable until they get bigger of being able to eat away the things that they need to eat and kill and consume. So that's why we run along a lot of problems if we only have the new guys and not the older people. So here's a good way of remembering this. Ever since COVID, we have had brand new nurses come in because all of the old nurses said, deuces, I'm not going to die. And that caused a lot of problems. So now in the hospital setting, we have a lot of new people who aren't mature in their understanding of the nursing process because they're new, right? They're going to be wet behind the ears. Whereas there are only a few of those mature cells, i.e. old people like myself who've been doing this for quite a while, who are responsible for trying to teach the younger bloods how to become, the mature, seasoned veterans that they need to be. And that causes a lot of complication. It causes complications for many reasons. For example, the younger guys, because there's so many of them and there's so few of the mature cells, trying to send those transmissions over to them and those responses to let them know what they're supposed to do is difficult, because it's hard to scream in a crowd of 1,000 people when you only have one voice. Does that make sense? So try to keep that in mind. We're going to move on to macrophages next. So macrophages come from the committed myeloid stem cells in the bone marrow and form the mononuclear phagocyte system. So anytime I say phagocytosis, just think eating. It's just easy to remember that for me. The stem cells form monocytes, which are released into the blood at the stage. Until they mature, monocytes have limited activity. Most monocytes move from the blood into body tissues where they can mix with macrophages. Some of these macrophages become fixed in position within the tissues, whereas others can move within and between tissues. Macrophages in various tissues have slightly different appearances and names. The liver, spleen, and intestinal tract contains a large number of macrophages. The function provides protection in several ways. The cells are important in immediate inflammatory responses and also stimulating longer lasting immune responses of antibody mediated immunity, or AMI, and cell mediated immunity, or CMI. Specific macrophage functions include, let me think about it, phagocytosis, repairs, antigen presenting, processing, and secretion of cytokines that help control the immune system. So the inflammatory function of macrophages is phagocytosis. Macrophages can easily distinguish between self and non-self, and their large sizes make them very effective at trapping invading cells. Unlike neutrophils, macrophages have long lifespans and can take part in many phagocytic events. So basophils, even though it's not necessarily listed here, basophils are important because they come from the myeloid stem cells and make up only about 1% of the total circulating white blood cell count. They cause the manifestations of inflammation. So basophil function results in actions on blood vessels through the activity of basophil chemicals, or what they call vasoactive amines. The chemicals include heparin, histamine, let me think about this, serotonin, kinins, leukotrienes. I think that's it. Yep, that's it. When released into the blood, most of these chemicals act on smooth muscle and blood vessel walls. Heparin inhibits blood and protein clotting, which is why we use heparin often when we're dealing with someone who has a really, really hard time with their blood because they've been smoking for 55 years, 3 packs a day, are hardcore drinkers and have random chest pains and blow it off like it's no big deal. Well, they come into my hospital with, random chest pains that are acute. And what do? We throw them on heparin as fast as we can so that we can make that blood go from pancake syrup to flowing like water, just like we need it to do, so that we don't have any other issues. And so they don't die. It's that simple. So that would be heparin. Heparin inhibits the blood and protein clotting. Histamine constricts small veins, inhibiting blood flow and decreasing venous return. This effect causes blood to collect in capillaries and arterioles. Kinins dilate arteries and increase capillary permeability. These actions cause blood plasma to leak into interstitial space, or what they call vascular leak syndrome. There's also eosinophils or eosinophils. Sorry, that's eosinophils is what you are call it in the UK. So let's do it our way. So it's eosinophils. There you go. They come from myeloid line and they contain many vasoactive chemicals. Usually, we're only talking about 1 to 2% of the total white blood cell count is composed of the eosinophils. So eosinophil function is very active against infections of like parasitic larvae and almost limits inflammatory reactions. The eosinophils granules. Lord, I love you so much, little girl, but you're making this incredibly difficult. Sorry, we got a tired one. Let's see, where was I? Eosinophils, granules, got it. So they contain many different substances. Some are enzymes that degrade the vasoactive chemicals released by other leukocytes. This is why the number of circulating eosinophils increases during an allergic response. Phagocytosis. Key process of inflammation is phagocytosis, or the engulfing and destruction of invaders. So I look at them as like the titans of yore, right? Back in Greek and Roman mythology, the Titans. So one famous Titan is Cronus, and he gave birth to Zeus. Well, obviously he didn't, but he got really upset with Zeus and was super concerned that he was going to take over his place as, you know, the king of kings, if you will. And in the Greek lore, he actually swallowed him. So that he could keep him in a latent state so that he wouldn't be able to destroy him and take over. So when I think of phagocytosis, I think of, you know, the Titans that eat their children so they won't be overthrown by them. Pac-Man is a good one too. We can look at the Pac-Man and eating the balls around and the little cherries or whatever so that you can, you know, charge up and get those guys out of the way and kill those ghosts, right? I just realized that most of you guys are younger than I am, so that may or may not resonate, so I apologize. But just keep in mind, big guys eat little guys that are invaders. Easy peasy lemon squeezy. So this action also rides the body of debris after tissue injury. Neutrophils and macrophages are most efficient at phagocytosis. And it involves 7 large steps that we really don't need to go into, to be quite fair, unless you absolutely want me to get into that. But I think you guys got enough to deal with anyways. So exposure and invasion occurs as your first step when we're dealing with this, and the leukocytes that engage in phagocytosis and stimulate inflammation are present in the blood and other extracellular fluids. So for phagocytosis to actually start, the body must first be invaded by organisms. Otherwise, there's no need to do any of those things. Those include foreign proteins or debris from damaged tissues as well, so keep that in mind. The process is triggered just by injury or invasion. Attraction is also needed as a second step because the phagocytosis can occur only when the white blood cells come into direct contact with the target. So antigen invader or foreign protein. Some substances or chemotaxins attract neutrophils and macrophages. Damaged tissues secrete chemotaxins and release debris that can combine with the surface of invading foreign proteins. So adherence is important because it's stage number 3, first off. And it also, it requires, how do I say this easy? It requires phagocytic cells first binding to the surface of the target. So easy, adherence, it's got to stick to it, right? Opsonins are substances that usually increase contact of the cell within its target by like coating the target with an antigen or organism. Think of it like a thin coated shell on an M&M. During inflammation, coating the targets makes it easier for phagocytic cells to stick to it. That way it can eat up the foreign bodies. And many substances can act as opsonins. Some are particles from dead neutrophils, antibodies, and activated or fixed complement components. After that, you'll have your recognition, which occurs when the phagocytic cell sticks to the surface of the target cell and recognizes it as a non-self. After that, you're going to have cellular ingestion, which is needed because the phagocytic destruction occurs inside of the cell. So the target cell is brought inside of the phagocyte cell by phagocytosis or engulfment. The cell binds its membrane around to engulf the target cell and to form a vacuole. Phagosome formation is next, and that would be stage 6. Where it occurs when the phagocytes granules are inside the vacuole, and these granules break and release enzymes that attack and ingest the target. And then finally you have degradation, which is the enzymes in the phagosome digest the engulfed target physically, and the target is broken into smaller pieces until only small particles of debris remain. Okay, so here's the good news, since I just ruined everyone's brain. The sequence of inflammatory responses is in 3 stages. The sequence to the same, regardless of the triggering event, doesn't have much variance. I will say that some of these stages overlap one another, so just be aware of that. Is it that big of a deal in the whole grand scheme of things? No. But just know that they do sometimes flow into one another, and sometimes are interdependent. Yikes. All right, so responses at the tissue level cause the 5 cardinal manifestations of inflammation, which is warmth, redness, swelling, pain, decreased function, all of the things that you would expect to get. Stage 1 is the vascular part of the inflammatory response, where injured tissue and the leukocytes in the area secrete histamine, serotonin, and kinins that constrict small veins and dilate the arterioles in the area of injury. Now, these blood vessel changes cause redness and warmth of the tissues, and this increases the blood flow delivery of nutrients to injured tissues to try to get it to heal faster. Blood flow to these areas increases, or what they call hyperemia, and edema or swelling forms at the site of the injury or invasion. Capillary leak also occurs, allowing blood plasma to leak into the tissue. And this is really important because the response causes swelling and pain. And edema at the site of the injury or invasion protects the area from further injury by creating a cushion of fluid. Also, the extra fluid also can dilute any toxins or organisms that have entered the area, so keep that in mind. The duration of these responses depends on the severity of the initiating event, but usually they subside within about 24 to 72 hours. So the macrophage is the major cell involved in stage 1 of the inflammation. So again, the macrophage is the major cell involved in stage 1 of inflammation. The action is rapid because macrophages are already in place at the site of injury or invasion. They're ready to throw down, right? They're ready to go. This action is limited because the number of macrophages is so small, because remember, the other ones went deuces and they ran off, and all we got is these little guys and a couple of these power players, right? So to enhance the inflammatory response, the tissue macrophages secrete several cytokines. One cytokine is what they call colony stimulating factor, or CSF, which triggers the bone marrow to shorten the length of time needed to produce white blood cells. So we go from like 14 days to like a matter of hours, and they do this as an emergent response. Now, the downfall is sometimes they're not very smart, but it's something, right? Like, you ever heard the phrase, well, at least it's the body? I mean, that's kind of where we're at in the world. So some of these cytokines also increase the release of neutrophils from the bone marrow and attract them to the site of injury or invasion, which leads to the next stage of inflammation, which is stage 2. And that is the cellular exudate part of the response. So in that stage, neutrophilia, which is an increased number of circulating neutrophils, occurs. So what does that mean? So it means exudate in the form of pus occurs containing dead white blood cells, necrotic tissue, and fluids that escape from damaged cells. The most active cell in this stage is the neutrophil itself, and under the influence of the cytokines, the neutrophil count can increase from 5 times within 12 hours of the onset of inflammation. That's why you have these crazy cell counts, right? So at the site of inflammation, neutrophils attack and destroy organisms and remove dead tissue through phagocytosis. In addition, the acute inflammation, the healthy person produces enough mature neutrophils to keep pace with the invasion and prevent the organisms from growing, which is great. At the same time, the white blood cells and inflamed tissues secrete cytokines, which allow the tissue macrophages to increase and trigger bone marrow production of monocytes. The reaction begins slowly, but the effects are long-lasting. So during this phase, the arachidonic acid cascade starts to increase the inflammatory response. This action begins by conversion of fatty acids in plasma membranes to the arachidonic acid. The enzyme or COX converts the arachidonic acid into many chemicals that are further processed into substances that continue the inflammatory response in the tissues. Some of the substances known as mediators, because they promote continual inflammatory responses, include histamines, leukotrienes, prostaglandins, serotonin, kinins, I think that's it. Many anti-inflammatory drugs, including NSAIDs, stop the cascade by preventing the COX system from converting into inflammatory mediators. Do you need to know this for your test? No, this is crazy hard stuff. I would never expect you to have one of these things on an NCLEX, which is talking about disease process. Keep in mind, guys, I'm trying to give you a quick patho review. There's a lot of players. You're going to remember a lot of this. A lot of this you're going to have to brush up on. So I'm trying to give you the quick version of how this works. And it is incredibly complicated. And some of these names are incredibly ridiculous, which is why I'm stumbling over them. So just know to take your time with this. Try not to freak out because, again, there's a lot of stuff in here. The things that I'm going to ask you are going to be much simpler than the things that I'm mentioning right here, but I want you to understand how this works. So when an infected stimulating inflammation lasts longer than just a few days, the bone marrow can't produce enough to release more mature neutrophils to keep up the pace with the growth of the organism. So in this situation, the bone marrow begins to release immature neutrophils, reducing the number of circulating mature neutrophils. And this reduction of mature neutrophils limits the helpful effects of inflammation and increases the risk for sepsis. And that's when you will see problems like overnight labs go from white blood cell count of 15 to 29. Womp womp womp. We're nowhere in trouble. Side note, I want you to remember that sepsis, lots of people think that sepsis has a variant in degree of temperature, which it does. It has usually comes with a much lower blood pressure, usually comes with a tachycardic state to try to compensate for that lower pressure by pumping harder. However, the first sign before any of this craziness is disrupted in the system, your first vital that is absolutely going to be affected is your respiration rate. Yes, I said it, your respiration rate. The one thing that nobody cares about is the one thing that we need to focus on first. Because if someone's respers go from 12 and then they become post-surgical, perhaps they had an appendectomy, the action of the injury produced by the surgical procedure itself will cause a white cell count to go up substantially. We see it often. People go, why? Oh, for the love of Pete, this crying child. I'm so sorry. So I'm going to grab this kid while I try to explain to you at the same time and not lose my train of thought. So specific to surgical procedures, you'll see someone go in with an appendectomy, and prior to the appendectomy, they will have a white cell count of 14 or 15, indicating that something's wrong, right? Because this appendix needs to be taken out before it bursts. Well, they take it out, no problem, and then they do another white cell count at 4 in the morning, which is pretty standard, and oh boy, we've gone from 12, 13, 14 to into the high 20s. And that's because the act of the injury of the procedure itself sends along these signals and mediators. So you're going to see this crazy fluctuation in white cell count. And remember, it's because there's not enough of the big guys. So the little guys come in, but they really can't pack much of a punch. And that's why we have these problems. So finally, stage 3. features tissue repair and replacement. Now, although this stage is completed last, it begins at the time of injury and it's critical to the final function of the inflamed area. Now, some of the white blood cells involved in the inflammation start the replacement of lost tissues or repair of damaged tissues by inducing the remaining healthy cells to divide. So, in tissues that can't divide, white blood cells trigger new blood vessel growth, or what they called angiogenesis. Wow, I really ruined that. Sorry, I'm holding a child's foot right now to make them not fall off of the couch. It's called angiogenesis. Hi, thank you, brain. And scar tissue forms. So because the scar tissue does not behave like the tissue it replaces, the function is lost wherever the scar tissue forms. And that makes sense because wherever there's scar tissue, it's going to be a thicker layer. So therefore the nerve endings that are up under it are going to be harder to trigger. Thus, you're going to have loss in sensation. So, duh, makes sense. So let's see where I was in my notes. The degree of function depends, or the degree of the functional loss depends on how much normal tissue is replaced by scar tissue. So, for example, when heart muscles are destroyed because of myocardial infarct or a heart attack, scar tissue forms in the area to prevent a hole from reforming in the muscle wall at the area of ischemia where the cells die. So remember that the heart muscle is non-dividing tissue and that the heart cannot replace those muscle cells. So this is the best way to just literally do like a patch job. The scar tissue serves only as a patch. It does not contract or add in any way to the heart muscle. So if 20% of the left ventricle is replaced with scar tissue, the effectiveness of that left ventricle contraction is reduced by 20%. So scar tissue is not necessarily a great thing. Inflammation alone cannot provide immunity. Inflammatory cells must interact with lymphocytes to provide long-lasting immunity. Long-lasting immune actions develop through antibody-mediated immunity, or AMI, and cell-mediated immunity, or CMI. So inflammatory response, the fibrinogen is activated to fibrin. It strengthens the clot formed by the platelets so that it can try to trap things where it needs to be trapped. And again, with clots, we want to trap bacteria. We want to prevent the spread of bacteria. It's a framework for healing that works very well. And the platelets release growth factor to initiate the healing process. And again, this is tied in with the last slide. I kind of merged the slides talking about all of these things, so I don't want you to get too caught up in the slide itself. Get more caught up in what I'm saying, because we're probably going to jump slide to slide and mold slides while we're doing this. But just for the purposes of you keeping your talking points, these are the things that are going to be the quote-unquote hot spots I want you to keep your brain focused on, okay? So we're just going to move on past this one. And we're going to move on to the directional migration of white blood cells to the site of injury, which we just talked about. We talked about the neutrophils and the monocytes and how, we want all the big players that we can possibly get, but sometimes you just have to pump them out the best you can. And you have your little guys to help out with their little tiny shields and hope that that's going to be good enough to get where you need to go in the world. Although it absolutely is going to make things very difficult, like we just discussed. So we're going to move on to the next slide. And again, we're talking about the pus formation when we go through this cellular response. We talked about the time frames, we talked about the short lifespans, and how we have dead neutrophils, bacteria, and cell debris that accumulates as the pus. Now, one thing I want to remind you of, and this is for previous slides, when we're talking about pus formation, a lot of times we're going to have to document this, and I don't know how to say this without being funny, haha, but I cannot tell you how many times I have seen a doc who is a resident who has a note in the H&P, which is the history and present illness, that talks about pus and uses the word pussy. Now, while that is a great idea, because if something is pussy, that tells us there is a lot there, can you imagine what that would look like in written form? So just be mindful that we're going to say excretes excessive amounts of pus. versus defining the tissue as quote unquote pussy, which is going to be a big problem. So I say these things not to be funny, haha, because it is funny, haha, let's all be real. But I really say this because nowadays, as of April of last year, people have direct access to all notes that are written by nurses, docs, OT, PT, ST, case management, et cetera, et cetera. So now we have to really, really be on the lookout with what we write, because when we say silly things and don't think anything of it, because these are common medical terms that we would normally use, which are appropriate terms, by the way, they could be quite the problem when we're dealing with the basic English language. So keep that in mind so that we don't have to worry about those things. Specific to this slide, remember how we talked about the left shift and what that meant? It meant there wasn't enough. So we only had a few big players and an excess of the little guys. So this is going to cause a problem. All right, so we are going to kick on past the slide since we've already talked about this. Please keep in mind phagocytosis. I can't tell you how much you're going to use the idea of phagocytosis. So please understand this concept. If you need to go back and listen to a couple slides ago when we talked about the whole entire process and how it works, do so. Khan Academy is a good reference as well, or you could just YouTube a quick version of what that looks like, just so you understand that concept, because that absolutely is going to come back to haunt us briefly. But the biggest deal that I think you need to know isn't necessarily how long that they're there, like 3 to 7 days. I'm never going to ask you those silly things. But I do need for you to understand just what it means, what it transforms into, right? The monocytes transform into the macrophages, and then they have phagocytosis. So as long as you understand just that little bit right there, I believe that should be enough informational direction to get you where you need to go in the world. And here is the last bit of the big synopsis that we had, where we are going over monocytes and their role in fusion to form these multinucleated giant cells, which leads to granula formation. And then, of course, we touched bases on humoral and cell-mediated immunity. All right, and then again, we're just rehashing the inflammatory response of the chemical mediators, which gives you histamine, serotonin, kinins, the complement system, prostaglandins, leukotrienes, and cytokines. All right, so inflammatory response with enzymatic cascade. So an enzymatic cascade is basically a sequence of successive activation reactions involving enzymes, which is characterized by a series of amplifications stemming from an initial stimulus. So the product of each preceding reaction catalyzes and is consumed in the next reaction. So an example of this would be blood clotting, where a timely response is needed because you're bleeding out, right? So the cascade first activates a clotting factor, followed by the activation of the next clotting factor, and so on and so forth, until the final cross-linked fibrin clot is formed, okay? Another example of this would be following the binding of an allergen to a receptor bound, bound area on a mast cell, right? So I feel like that's going to be a little much for you guys, so I'm going to leave that alone. But just remember that enzymatic cascades, they can also play a role in the immune system because the complement cascade works with the body's innate immunity by cleansing the pathogens from the organism. So it proceeds through the 3 major pathways, the classical, the alternative, and the Manus binding lectin. And the end product results in large-scale amplification of cell-killing membrane attack complexes, right? So basically, enzyme cascade, it cascades a lot of enzymes that eat a lot of things that kill a lot of bad stuff, right? So it enhances phagocytosis, it increases vascular permeability, chemotaxis, remember your Latin? chemo, chemical, taxis, movement. So movement around the area, and then cellular lysis, and lysis is to kill it or to lyse it. So prostaglandins, they are hormone-like substances. Technically they're lipids, but hormone-like, that affect several bodily functions, including inflammation, pain, and ironically uterine contractions. So healthcare providers sometimes use synthetic forms of prostaglandins to treat several conditions, believe it or not. Some of them that I can think of off the top of my head is glaucoma, erectile dysfunction, things of that nature. So basically, they're a group of lipids with hormone-like actions that your body makes primarily at the sites of tissue damage or infection. There's several different types of prostaglandins, and they play several essential roles in regulating body processes, including blood clot formation at the site of injury, blood flow, healing, inflammation, like I mentioned earlier, labor-induced induction in pregnancy, familiar to the uterine area, menstruation and ovulation as well. But for the purposes of this, we need to know that the arachidonic acid in the cell membrane, following injury from the active prostaglandin, is going to be converted into these three here, which is the prostaglandins or the PGs, the thromboxane, or the leukotrienes. Examples, again, corticosteroids, NSAIDs, an ASA or salicylic acid inhibits steps in this pathway. Why? Because what do these things do? Oh yeah, they pop holes in things and make things bleed faster, which is a big problem in the world, which is why we tell you to basically stay away from these things if we can at all help it whenever we're trying to have fast physical tissue healing from traumatic injury. So here's another beautiful example of how things have arrows and make you feel like you don't know what's going on. I just want you to think of an example of all of this is when you cut your finger, prostaglandins would play a part in your body's response in the following ways. Okay, so the affected tissue in your finger will release prostaglandins that signal the platelets in your blood to stick together to form a blood clot at the site of the injury in order to stop the bleeding, right? That happens all of the time. We've all had that happen before to us. The affected tissue will release the prostaglandins to narrow affected blood vessels to try to lessen the blood loss. That's why we have this big thing over here that says inhibited by NSAIDs and salicylic acid. We also talked earlier about the cyclooxygenase pathway and what that means. And I want you to think about, specific to the idea of prostaglandins and how this affects the pathway, is the affected tissue will release the prostaglandins that trigger the inflammatory response that causes the vessels to leak fluid into the tissues, creating swelling. So this helps isolate the foreign substances that enter through the broken skin from further contact to your body's tissue. It also attracts white blood cells called phagocytes, dun, 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 that eat the germs or the damaged cells. And once the injury is healed, the affected tissue will release prostaglandins again to break up the blood clot and remove it since it's no longer needed. So prostaglandins are extremely potent biologic substances that are produced in nearly all of the cells of the body in response to cell membrane injury. And they're abundant in bone and are potent regulators of bone cell function. Specific to what we're talking about here, the induction of the COX-2 expression and the presence of the terminal synthesis and the prostaglandins that are pro-inflammatory are potent vasodilators that contribute to increased blood flow and edema. And we talked about why that was important earlier. It also inhibits platelet and neutrophil aggregation. It sensitizes pain receptors and it stimulates a fever, which also sends a response to the body to start to fight off infection in turn. So thromboxane. So how does thromboxane cause clotting? So To get super confusing and then get super simple, here are the basic facts. So when thromboxane binds to its receptor, there's an influx of calcium ions, which directly increases the contraction of the smooth muscle cells. Now, what this means to you is it aids in the platelet aggregation because the platelets are close to each other. Therefore, it clumps faster and creates a greater clot formation. That's all you need to know about this. All right, so leukotrienes and the allergic response. So leukotriene causes tightening of airway muscles and the production of excess mucus and fluids. These chemicals, they play a key role in allergies, allergic rhinitis, asthma, and also cause a tightening of your airways, making it difficult to breathe. So try to keep in mind with last slide, leukotriene modifiers are also called leukotriene receptor agonists. They're a group of medications. They can help prevent breathing problems associated with allergies, asthma, chronic obstructive pulmonary disease. So I want you to remember that regarding the previous slide. And in this slide, what I want you to know is that exudates are inflammatory in nature and occur because of vascular permeability caused by the release of inflammatory mediators from the inflamed tissue. Now, neutrophils are typically the predominant cell type in most exudates, but macrophages and to some extent lymphocytes are also increased in this case. All right, so MC is a 60-year-old man with left foot pain, swelling, open area 2 centimeters in diameter with purulent drainage. He has a history of diabetes, hypertension, but states he is not taking his medications regularly. Hey, listen, this is going to happen all of the time. So this is going to be our case study that we're going to be going over. So try to remember these little pieces of information. 60-year-old man, left foot pain, swelling, erythema, 2 centimeter diameter, open area, purulent drainage, diabetes, hypertension. He's not taking his medications. As we all know, diabetes and diabetes tests and supplies are the reason that we have impaired tissue healing, which is always a fun problem to have in the middle of a hospital. Yeah, she's excited about black toes too, so there you go. And this is a pretty easy slide because we've already hit on all of these. Inflammatory responses, clinical manifestations, it's red, it's hot, there's pain, there's swelling, there's a loss of function because guess what? It hurts really, really bad. These are things that I do want you to know for the purposes of an exam. I know we've been hitting some really hard stuff, but this stuff I feel like is the basis of basic nursing function. So redness, heat, pain, swelling, loss of function. These are going to be absolute responses of our body saying, hey, I'm ticked off. I don't like this. And this will trigger the responses sent to the rest of your body to fight off the invaders. So here's a prime example of what that looks like from written form to visual form. So not only can you see the top of the hand is super puffy like a boxing glove, looks like we might have some cellulitis because it's awful, awful shiny skin. It's red. It's hot. I see pus. I see stitches that should have been taken out a week and a half ago because they're literally, if you look like in the middle, you can see where it's kind of embedding and degrading into the healthy skin, which means, these guys are no longer surface and they're so far in deep that they're going to be a headache to pull out, which is always my favorite. When I have to remove stitches that someone's waited 2 weeks extra to get taken out. But this is what we usually see. If you notice there is what looks like a pin marking down towards the left side, that is what we call a zone of demarcation. You're going to do this quite often whenever you have someone come in with this because we want to see, is the medication working? And although our numbers from our white cell count is a good indicator, what is the best indicator of the patient getting actual healing process is to see that zone of demarcation receding rather than getting bigger. So we will draw a line around the red mark like most of you techs have done before for your nurses who were too lazy and said that they had to go chart something when they really didn't. And they went to go get a Coke instead. Like these are the things that we have you do that for. So as a nurse, you're going to know to delegate that to your tech and get a little bit back of what you were paid. So yeah, there you go. There's your visual learner right there. So MC and his nasty arm has given us a blood pressure of 160/90, which isn't good. A heart rate is 110. Meh, I'm not so excited about that. Look at the respirers though. Respiration rate 22. Yikes. We're getting towards the higher level of capacity when we're dealing with respirers here. And then, of course, when we end up hyperventilating, that causes more issues. We'll get into that when we talk about respiratory. I'm not doing that right this second. And then temperature of 102, that's also incredibly normal to see in these guys. So your best bet for this is obviously going to be a Tylenol. You don't want to do anything that's going to increase the viability of a clot formation reversing. So we don't want to mess with the other things. I literally am a room away and you can hear my kids screaming. I'm so sorry. So yeah, this is pretty typical. We usually with these guys have like a PRN Tylenol order put in like every 6 hours. But again, you kind of got to watch out for that too, because there's a cap that you need to come off. If you can think about what that Tylenol level is going to be, go ahead and tell yourself what it is right now. And I'll give you about a half of a second to let you know that 4 grams is our barrier. So we don't want to go into excess of that over a 24-hour period, or we're going to cause some liver problems, and that's never a fun day to stack onto this ridiculousness that is him being sick because he can't be bothered to take his medication or take care of himself. So again, with this, we're going to see an increase in white cell count, or what they call the shift to the left. We're going to have muscle weakening and achiness. We're going to be nauseous. We're not going to want to eat. There's going to be a higher pulse and a higher respiration rate. There's going to be a fever, obviously, that's going to be present while we're trying to retroactivate all of this damage. And I want you to remember that, again, the fever is an onset that's triggered by the release of the cytokines, especially those prostaglandins. And also know that we initiate these metabolic changes in temperature regulating centers in the hypothalamus to raise the thermostatic set point, because the hypothalamus is where we have that temperature regulation. We also have autonomic nervous system to increase the muscle tone and shivering while we have this fever, which reduces perspiration and peripheral blood flow. And epinephrine will increase this metabolic rate. So why do people get chills when they have a fever? Well, there you go. So from the hypothalamus, we have the production of the PGE2, which raises the thermostatic set point and tells the body, you can handle more. Then the autonomic nervous system responds with, these heat generations, the increased muscle contraction, the shivering reflex, because of the heat conservation from the cutaneous vasoconstriction and decreased sweating. So that those two concomitant with one another create that traditional fever that you see in someone who's very ill. So one thing I always like to think about that's super frustrating for me is when you have a patient who literally is freezing cold and has a temperature far into the hundreds. What's the first thing that they want you to do? They want you to throw warm blankets on them, but what's that going to do? Well, it's going to cause more trouble. So what's the answer? And the answer is you got to give them, tepid water to bring down that temperature if our medication isn't working. And a lot of times our medication works the first couple of times, and then after that, the body builds a tolerance to it. This fever really likes being feverish, right? Because it's his only player in its whole life is to make things hot, right? And it literally can't do much else. So it gets really irritated by that, and it builds an immunity to these medications sometimes very quickly. And I am sometimes left putting ice baths with alcohol, like the old school nurses did a billion years ago, up under the arms, at the back of the neck, behind the kneecaps, at the feet, and everyone's favorite, into the groin area, because those are the spots that regulate temperature very quickly if you've got to turn it around and this person is going to die. So try to keep that in mind, because as much as you want to cover these people because they're freezing and they're little old biddies and they're adorable, you got to look at the bigger picture and realize that the best thing that you can do at that moment, if you can't self-medicate and fix the problem, is to use these ulterior or alternative methods to reduce that temperature fast before the brain starts baking. Now, the fever isn't a terrible thing. I want you to keep in mind, it does a lot of good. So what it does is it heats everything up, obviously. And the one thing that doesn't like heated is microorganisms. So it increases the phagocytosis. It increases the rate of death. And consumption of these microorganisms. It increases the proliferation of T cells, which is kind of a big deal, and it increases the interferon activity. So there are good things related to a fever if we don't get too ridiculous. And one of the prime things that I can think of that's a good example is we won't treat a fever unless it hits 100.1 or greater. If it's what they call a low-grade fever, we'll let it ride, because we want our body to try to start the healing process by ticking off, these microorganisms, by making them hot and trying to bake them out. So keep that in the back of your brain if you can. And again, we got our buddy. And he has a serum glucose of 350. Fun. White cells 19. I see this all the time. Neutrophils 80%, 12 bands. So we're getting infection, and this serum glucose is obviously going to be on the higher level, because infection and sugar are best buddies. They love each other. And this is why you will typically see someone who has uncontrolled diabetes, who has this incredibly terrible skin that's breaking apart and is ulcerative, and there's not a whole heck of a lot you can do, because again, they are non-compliant. And when you get sick like this, your glucose is going to go up by default, because it just loves to make skin worse, and skin loves to munch on, the reminiscent pieces of donut that he had for breakfast when he said he was going to eat healthy. I mean, it is what it is. So keep these things in mind. This is very typical with a person who has a pretty nasty infection because they haven't managed themselves well. Okay, so I think we have gotten through all of the scary stuff. So now let's get to the fun stuff, which is the easy stuff. So acute inflammation lasts 2 to 3 weeks, usually no residual damage after the healing. Remember, neutrophils are the predominant cell type at the site of inflammation, versus subacute, which has the same features as acute inflammation but persists longer in a matter of weeks or months. Chronic inflammation, however, lasts weeks, months, or years. The injury persists or repeats injury to tissues. Predominant cell types are lymphocytes and macrophages, may result from changes in immune response or autoimmune disease. So you'll see this again. I pick on diabetics all the time, not to pick on them, but because these are your typical guys that come in that have a wound, that usually starts off from trauma, usually stepping on something barefoot, which is why we always tell them put some daggum socks on your feet and don't walk outside barefoot to go get the mail. And then they get a small injury, which turns into a bigger thing, which turns into them later coming in and going, I don't know, well, my toe's black and halfway falling off. But here we are, right? So these are the types of chronic inflammatory responses you would have from someone who has a cellulitis that is just non-healing because this guy can't get his diet together, doesn't take his insulin or his metformin like he's supposed to, or Trulicity, or whatever you want to call it, whatever he's on at the moment, and just has a bad outcome as a result. So, health promotion. This is the fun part. This is where we prevent injury. We make sure that they have adequate nutrition and hydration so our body can fight against it like it's supposed to. Early recognition of inflammation. So, we need to educate these people. Believe it or not, these guys really don't know what to look for. They think part of tissue healing response is it being red. Which is kind of bizarre, but you'd be surprised at some of the things that I've heard before. A lot of these guys, too, try to do things on their own, through their own home remedies. I've seen these guys put Vaseline in wounds, yikes, that were still healing or sutured. I've seen people put toothpaste in wounds, thinking that because it's got baking soda in it, that somehow is going to kill the infection. Just silly ridiculousness. So it's our job to educate these people and let them know signs and symptoms, prevention, when to call, when to come into the ER. So, acute care, observations, and vital signs. Immunosuppressed patients will often say, I just don't feel right. I just don't feel good. I just feel kind of weird. Like I don't feel like myself. I don't feel right. It's usually what you get. I always get nervous with those guys because when I see that and then I see a higher temperature like 103, 104, we start getting into seizure territory and I start getting super duper nervous. So you got to figure out why it's doing that and determine the cause. Administer antibiotic to start to kill the infection. Make sure you got those PRN antipyretics. Anti means absence of or not. Pyro means fire, and then etic is the object of or the movement of or the idea of. So the idea of stopping a fever or heat. Just make sure that you keep those on deck because you got to stay right on top of it or it is just going to send the response to the body to say, hey, you know that one Tylenol I had 9 hours ago? We're just going to go ahead and absorb that and do a little bit better, but then just go ahead and rebound into something awful. So acute care, what we do is people who take corticosteroids regularly have a blunted response to fever, and illness may be severe. So we want to make sure, like I said earlier, that we use a cooling blanket, that we have something thermostatically set to a lower point with antipyretics, so that we can go ahead and manifest a lower temperature. So what essential patient teaching should you perform with this patient? And this is the type of question that I am going to take if I find an opportunity to take one of those, because this is the stuff you need to know as a nurse. So what essential patient teaching am I taking this guy? Well, first I need to find out what type of teaching he understands, because if you think he's going to understand all of these things, heck, we can't even understand it, right? So like, we're not going to be teaching them the cascades or anything of that nature. What we are going to say is, here's some signs and symptoms of bad. Here's some signs and symptoms of good. And these are the medications that you need to adhere to in order to get better faster. All right. So if you have any of X examples of signs and symptoms, these are triggers to let you know you need to take your little tail into the ER because things are getting worse and not better. So drug therapy, antipyretics, anti-inflammatories, your aspirins, your NSAIDs, these guys you want to watch out for. Obviously, if we have like a gunshot victim, we would want to go to something more along the lines of acetaminophen. Corticosteroids are often used as well to help with the body process of healing, to make things a little bit easier for obvious reasons, for breathing, for inflammatory mediated responses, et cetera, et cetera. So, when I think of rice, I think of the alternative, which is people who come in and have these swollen injuries and have been putting heat on it. So let's talk about how heat is the dumbest thing you can do for an area that's swollen, because what's it going to do? It's going to make it even more swollen. Yikes. So rice is the answer, which is rest, ice, compression, and elevation in that order. If you want edema and pain, throw heat on it and keep your foot down, you'll love it. You'll feel the throbbing and you'll be able to sing your favorite tune in perfect pitch with perfect rhythm because the throbbing will be your drums. So keep that in mind. Ice good, heat bad, 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 bad when you're dealing with an inflammatory process. Okay, wound healing, my favorite part. So, inflammatory response, we have to deal with regeneration, and in regeneration, we replace the cells and tissues with the same type like we're supposed to. Repair is the most common. Connective tissue does replace lost cells. Primary, secondary, and tertiary intentions. So here's how you should remember this. Primary wound healing or primary intention wound healing refers to when docs close a wound using staples, stitches, glues, or other forms of wound closing processes, right? Secondary wound healing or secondary intention would have wound healing occurring when the wound that cannot be stitched causes a large amount of tissue loss. So doctors will leave the wound to heal naturally in these cases. So these may be more common for wounds that have a rounder edge, cover uneven surfaces, or surfaces of the body where movement makes stitches or other closure methods impossible. I always think about when you cut your finger, if you cut it at the knuckle, you're kind of in trouble because guess what you do all day? You wag your finger. And it's just normal movement for us and we don't think anything of it. So it's just going to basically reopen that and actually in some cases make things a little bit worse. So that would be our secondary wound healing. Tertiary wound healing, or healing by delayed primary closure, occurs when there is a need to delay wound closing processes. This would be necessary if a doctor fears that they may trap infectious germs into a wound by closing it. So in these cases, they may allow the wound to drain or wait for the effects of other therapies to take place before closing the wound. Now, my primary example for this one, in my experience, is when you have like a gnarly cyst. So they'll pop it open and make a very, very long line of demarcation and then open that up to get all of the stuff out. And as they're getting all of that dead stuff out, they will leave it open to kind of drain and they'll just pack it really well. And that packing has embedded ointment in it to help with the wound healing process. And they'll continue to pack it until that packing gets a little more shallow, a little more shallow, a little more shallow, but they'll keep it intentionally open to drain so that it kind of drains the bad and the good out. And it also promotes that extracellular fluid to push out the bad stuff. So that would be a tertiary intention. And here's some quick examples of the types of wound healing if you want to take a couple of seconds to kind of look at this. I want you to pay more attention to the idea of primary, secondary, and tertiary intention again. And I want you to look at the A, B, and C and kind of be able to decipher in a test question if it says incision with blood clot, if it says with fine scar, with large scar. It's going to give you these trigger words. Hopefully I'll have the opportunity to pick one of these that says, contaminated wound. So you know that it's going to be a tertiary versus edges approximated with suture, which is going to be more of a primary, which is your A, what I would call a figure A2, or the middle one right here. So just kind of take a quick look at it. Don't commit a lot of it to freaking out in memory. Don't throw it on slide cards. Just kind of get an idea of the concept of if it's easy, then it's usually primary. If it's a little more difficult, it's secondary. And if it's nasty and it needs to be left open for a hot minute, then it's tertiary. So of course here we have JP, a 71-year-old woman, had open abdominal surgery for a bowel obstruction. Never good. Midline abdominal incision intact with steri strips. She is overweight and diabetic. So obviously, if you're overweight and you have an abdominal incision, depending on where that abdominal incision is, this one I can tell you, usually for a bowel obstructions usually happen at midline or slightly lower. And usually if you are overweight, you have the classic quote unquote Dunlap or fat patch, or what do they call them? um, what do you, kangaroo, um, kangaroo pouches or whatever you want to call it. That's usually where it is, just as it is, right? So we have that to work against us, and on top of that, we're diabetic, so we have poor wound healing, which is going to cause a problem because it's easy to get infected if you have really large areas of tissue. Because when it folds in half, or if it gets under those folds and your incision line is there, it's just a host for moisture and for things to get stuck in there and to cause other issues. So hooray, we're excited about this. And again, we're talking about primary intention that we talked about earlier, which includes the 3 phases: the initial phase, the granulation phase, the maturation phase, and the scar. So again, keep in mind what the primary intention, secondary, and tertiary intention is, what the phases are. That may be on your test, to be quite honest. Again, I haven't seen what this mock test looks like, and this test bank that I get to choose from. But if I have an opportunity to do something that includes the phases of primary intention, I would focus on that because those are pretty important, to be quite honest. So I wanted to give you a little bit more text, even though I've already talked about all of these things. So initial phase, 3 to 5 days. Am I going to want you to know 3 to 5 days? Not really. I think that's a little silly. Edges of incision are approximated. They're sutured. These are the things I do want you to know. Blood fills in the incision area, clot forms, matrix for white blood cell migration, like we talked about way earlier. Acute inflammation reaction occurs. Capillary growth and migration of epithelial cells after the wound debris is removed. As far as this is concerned, granulation phase, 5 days to 4 weeks. Fibroblasts migrate into the site, secrete collagen to form a scar. I think that's pretty important. You need to know what the wound looks like, so those are good as well. Risk for dehiscence is a big deal. I want you to keep that in mind because that's always a bad day, and we'll get into dehiscence here in a second. And then the surface epithelium begins to regenerate, so keep that in mind with primary intention so you understand the phases of how this works. And then here we go again with the next phase, maturation and scar contraction, 7 to several years. Collagen originated collagen organized. Wow. Okay, I've had it, and I'm only at slide 45 of 112, so this should be fun. Mature scar forms, avascular and pale, sometimes more painful. And then, of course, we can read the secondary intention and what occurs with that. Please understand what it means for secondary intention. Please understand where the granulates form. In this case, in the edges and from the bottom up in a larger scar. So for tertiary, I want you to remember delayed primary intention due to delayed suturing of the wound. Again, we're doing this because there's something in there that could still brew more bad things, right? So we keep it wide open and we keep it nice and disinfected while it's in the healing process. So when we're dealing with this, we need to know the break specifically because it's important to know if it's surgical or non-surgical, right? If it's non-surgical, did it come from a rusty knife, right? Because we know surgical knives are sterile, right? Is it acute or is it chronic? Because chronics usually are kind of a nightmare to deal with versus acute, which we can go ahead and snip it and clip it fast, right? So the depth of the tissue loss is always important as well because superficial, partial thickness, or full thickness is going to dictate how our wound healing is going to look. So skin tears. I cannot tell you how often people call skin tears pressure wounds. That's a problem because any hospital is going to have to eat that cost if there is a non-documented pressure wound prior to admit. And what happens a lot of times is we get these older people who have very, very thin, translucent skin, and we go to grab the bath blanket to push them up to the top because they can walk into the hospital, but by the time we get them in the bed, they can't physically lift themselves 6 inches, which makes no sense to me, but hey, here we are. And they get a tear on their buttocks and they call it a pressure area. And guess what? Now we've acquired that cost, which means at the end of the year, all of that beautiful unit funded money is going to go to that and not to the nurses and the techs and the materials that we need to do our job effectively. So make sure that you pay good close attention to it, because you can tell the difference between a shear friction versus a blunt force versus a pressure, okay? And we're going to talk about what those things look like in just a second. All right, so we got the big complications of healing, adhesions, band of scar tissue. These can get pretty nasty, to be fair. Some of these can be deforming, especially if they're on the face or somewhere that other people can view it and make nasty comments about it, because guess what? People aren't just trolls on the internet, they're trolls in person. We have things that could cause some minor deformity, which can cause us to have abnormal gaits depending on if it is at an area of a ball and socket joint or if it's at a hinge area where we bend often. Dehiscence is separation of the wound edges, and that will cause exposure and a good opportunity for bad things to come in. Evisceration is a bad day because intestines kind of pop out from the wound. Side note, intestines are super smart. So what we usually do when we have a stab wound and intestines are protruding is we literally stuff them back in like a Build-A-Bear and they find their way home. How crazy is that? Excess granulation tissue extends above the wound surface. That's also a complication. Again, if we're trying to have good mobility, sometimes that can get in the way of things. So here is dehiscence in its glory, and if you'll notice, there is a big wide open space. That's a big problem, especially if that is in the abdominal area, and I kind of feel like it might be just because the amount of hair, but it could be under the arm too, which is always a problem. So anytime and if you can see, the internal sutures are actually separated as well, and the external sutures have been removed. So that's a big problem. A lot of nasties can get in that thing. So you got to keep it nice and clean. You got to keep something covered over it. So one of the big problems of this is fistula formation, which is an abnormal passage between the organs or organ and skin. Obviously it causes infection. Obviously it will cause a hemorrhage or bleeding if it's in the right area. Really nasty scars that are raised and large and cause more problems than good. And then you got the keloid that you normally see. I've been a boxer for 20 years now, so the first thing I always notice is people's ears because they have those nice keloid areas. Fun fact, I got knocked so good one time that I had a nasty keloid on my left ear, and I physically had to have it removed, which means they had to cut it like the top of my ear in half. And it was a super fun not experience. So keep in mind those keloid scars, even though they are unsightly, sometimes they can cause physical damage if they're in the right position. Think about how a keloid would look if it were near your eye. I mean, it's raised, it's huge. That's why they call it like a cauliflower ear. Imagine if that were close to the base of your sinus cavities, right? That could also cause issues if you catch a cold because you can't have proper passage of the mucous membranes to excrete all of that junk that is stuck in your nose. And in other different circumstances that, you know, are familiar to getting in the way of things that need to operate and function normally. So here is a classic hypertrophic scar. It is unsightly. Is it physically damaging? It depends. Most of the time, no. It's just an abnormal response to wound healing. You get extra connective tissue that forms within the original wound marginal area. And it's not great if you are, you know, on the cover of Vogue, which obviously is not my case, but it's a problem because it's, you know, mentally damaging when your face is supposed to look one type of way and then it doesn't. My favorite keloid scar. So here's the big mamma jamma. If that is on your neck, I want you to try to imagine laying down and sleeping, because this is an easy soft tissue, by the way. This is hard tissue a lot of times. And imagine that pushing while you're laying down on your right side. So that limits your ability to lay comfortably in most positions, which is going to give you an absolute migraine and trigger the cause and effect that turns into you having, sternocleidomastoid muscle issues. And then that triggers down to your trapezius and gives you trapezius problems because, again, we're not having those body mechanics like we're supposed to. So it's going to cause a disruption in our muscle memory and cause pain. So here we go. Classic. JP, 3 days post-op, develops abdominal pain, fever, malaise. Wound opens, producing a large amount of drainage. So that's always a bad day, because when we think of all these things, the first thing we think of is infection. Something's got invaded. So we've got to clean it out. We've got to give antibiotic therapy. Sometimes we have to do a little fluid replacement depending on how sick they got. Sometimes they're nauseous and they throw up. So this is the beginning of the trickle effect of things not going well and needing to come in to get intervention. All right, cool. So this is where we get into what I'm looking for on an exam. I want you to know what you need to do in your assessment. You got to know the location. You got to know the size. You got to know the depth. You got to know the margins. You got to know the wound base. You got to throw it in a note. And the reason I say all of these things is, again, we're doing that pre-admission checklist that we have to go through, and anything that's not listed that just magically manifests whether we do it or not. And this is classic common. Wounds are almost never even discussed, even though you have to do a 2-person skin assessment, because it used to be 1 person. Now it's 2 people, because you have to have 2 nurses responsible for saying, I checked that person's skin. And guess what we still do? Because it happens every day, because it still happens, and I see it all the time. Is people go, hey, here's my OPID, da-da-da-da-da-da-da. Go ahead and just throw it in. And that's an indicator for 2 lazy nurses that aren't checking skin. And then all of a sudden, when there's a wound that pops up out of nowhere that's super deep, everyone's like, it wasn't there. I looked at all their skin, even though it's, 3 layers down. And obviously that didn't happen in 16 hours. Sometimes it can. Most of the times it's impossible. So please, 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 with a cherry on top, check it and go ahead and put in a review from Wound Care. That's a nursing order that you can put in. Just please have them do a quick check on it with recommendations. And it's, like I said, it's a standing nursing order that you would physically have to put in yourself under the orders tab. If you're using Epic or whatever, service you use, please make sure that you put in an eval and treat for wounds. So wound measurements are in centimeters. So make sure that you are doing your measurements appropriately. We don't want to get those mixed up with inches. It makes a huge difference. Make sure that you understand what the depth is. If there's tunneling is a big deal, because you physically have to put your Q-tip stick all the way down. Some of these tunnels will open up into a cave, right? So sometimes you'll go down and then you'll go to the right, and you can literally swirl the end of that stick in a very large circle, because tunneling doesn't mean it goes narrower. Sometimes it can tunnel down to an open area or pocket, as we call it. So I know that these are all self-explanatory, but I want you to keep an eye on these, because these are going to be trigger words I'm going to use if I can help it with checking these questions and picking them. I'm going to make sure that the word infection's in there, or that the word anemia is in there, or the word smoking is in there, or smoking, obesity, and diabetes, so that you are triggered to understand that this person has delayed wound healing. So pay attention to these. And here again, we talk about the people that we need to pay attention to: dietitians, let the physicians know that you found something if need be. Patient, sometimes the patient doesn't know they have a wound because they can't feel it. Make sure that you review these with the teams that need be. And if you notice wound ostomy, nurse is up at the top. Do these referrals, please. Again, make sure that we're cleaning these wounds as we see them. Do a basic wet to dry if they need packed. do something, right? Just don't leave them be. Even if you're cleaning them with just normal wound wash, please at least get something underneath that surface so that we can try to at least do something to stop the increase in those bad guys coming in. So JP is taken back to the OR for irrigation of the surgical site. Usually they use vancomycin, and a drain is placed into the abdomen, and she's started on an antibiotic. So drain, depending on what kind of drain you have, usually it's a JP drain. You need to keep a good eye on that. You need to check the color. You need to make sure that these guys aren't clotted. A good indicator that that drain is not draining properly is you'll have a slow trickle over an accumulation of 12-hour shift. You'll look and see, there's nothing in there. And then all of a sudden your patient will, out of nowhere, start screaming bloody murder to the top of their lungs and be like, my side hurts. And they're grabbing it and they're pulling at it. And you're going, you got a JP drain and it's fine. But what you don't realize is even though it's trickling down just a hair, there might be a pocket in there. So what you need to do is literally turn them to the left, turn them to the right, have them sit up, and you will literally get a flow, like a free flow of just fluid accumulation. Because remember, the more that fluid packs in, it's pushing on things, and those things are nerve endings, right? So that's why you're going to have this incredible amount of pain. Another thing that makes me a little bit more familiar with that process, or reminds me of that, is when we have people who have complaint of belly pain, who have catheters. Same concept, guys. Something is occluding the area and you've got to find out how to get it better. And a lot of times position change is your man. So make sure that you're flipping them one way, flipping them the other, having to move about, because that's when you will have the big cascade of fluid come through. And then all of a sudden the patient's relieved and doesn't need intervention for pain medication. All right, so clean wounds, closure devices, dressings, keep the wound clean. Make sure that you're using a sterile procedure if you can. Sometimes these are not sterile procedures if you end up doing home health later on. So you got to keep it clean as best as you can. Obviously, don't pick your nose and then stick your finger in the wound. Don't cough in the wound. What else have I seen before that's super stupid? Don't touch your shoes. Oh boy, here's one. Don't clean a floor that's got blood on it and then use the same gloves to then touch somebody's wound to pack it. I cannot tell you how easy your job as a nurse is going to be if you just use your common sense and don't do anything to create further injury by doing something that's shenanigans based, okay? Like, obviously, take those gloves off, put clean ones on. Don't touch icky and sticky and then go to clean. That's a terrible idea. I feel like this shouldn't even be a slide, but yet here we are. So make sure that you understand these things. And here's my JP drain. I use these often. We also have Penrose drains, which kind of look like flat straws. And their job is to just leach out into like another area. They're usually free flowing. They get everywhere. We moved to JP drains because they're just cleaner and they keep infection more compartmentalized because stuff goes out, doesn't go in. It's that simple. A lot of times these people, if they had complained of this pain, you'll have to flush that. And right up at the top of what we call that grenade, at the top of that is a little valve that pops open, and when it does, it accumulates air, it fluffs up. A lot of people will squeeze that grenade, close that cap, and let it go. That is not, I repeat, that is not the smartest way to do that, because you're not going to get the full suction that you need, right? You're not going to get that negative pressure. So what you need to do is go from the bottom and literally roll it like you're rolling a dollar bill, right? Roll it. And then once you get to the top and you, what I call choke up at the head right there, then you take that valve and close that valve. And then when you let go, you're going to get a free flow of fluid, like really, really fast, a gush. And you'll know at that point that you have it really well. Because if you do the squeeze and cap, that's the lazy man's way of doing it. And you never get the amount of fluid you need to get out. And that's why you constantly have pain. And that's why you're constantly taking pain meds, and why you constantly are constipated, and then you strain, and then you bust your internal sutures. Dun, 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 dun. See the full circle? So make sure you're watching these, okay? Here's another silly slide that says, hey, guess what? Contaminated wounds must be clean for healing to occur. Did you guys know that? I didn't think you did either. Sure. Debridement may be necessary. A lot of times we do what's called an IND, which is an incision and drainage. Sometimes we have to do a debridement as well, where we have just so much nastiness, right? That starts to get grosser and grosser. Sometimes these cysts don't heal well, or there's a secondary cyst up under the primary cyst that forms, and you have to go in there again and debride the entire area, which, yes, causes a borehole in the body, but everything is clean at that point and nothing is no longer contaminated. So that at that point we would then close that up or leave it open and packed if we need to, whatever the case is, so that we know that we do have what's called a fully clean surface. All right, cool. So JP's wound is red with minimal clear drainage, and her abdomen drain has been removed. So we're making a little progress. Her dressing care now consists of saline gauze covered by a dressing. When you're using saline gauze, cover it by a dressing. Make sure you got an ABD on top, because those usually suck the rest of the saline gauze that the skin isn't taking for healing. And it doesn't, drain out into their clothes. Priorities in first world problems are hilarious to me, because people will complain about their shirt being messed up, but they won't complain about the fact that they caused their wound to dehiss, which makes no sense to me. So make sure that you're doing these watertight dressings really well, so that people can focus on what matters, which is their wound healing, and not necessarily so much their JCPenney shirt going from white to slightly pink. So negative pressure wound therapy, suction that removes the fluid, the exudate, bacteria, and increases the blood flow to the base, which then increases the tissue healing. Monitor your protein levels, monitor your fluid and electrolyte balance, monitor your coagulation studies. Sometimes this is a simple wound vac, sometimes it is a complex wound vac, and those guys have a lot of drainage and a lot of blood goes with it, so therefore you're going to have these guys lose an entire gram of blood overnight. You'll be scratching your head why, and then you'll go look in your tank on your wound vac and realize that it's been changed over 4 times and it's full again. So just keep an eye on those guys, because when you're dealing with any type of wound vac that's on the spinal column, at a hip, those are really bloody areas in the abdomen. Those are really bloody areas and bloody surgeries. So you lose a lot of volume mass. And again, here's another one of those negative pressure wound therapies. Big deal. This is a completely destroyed femoral artery that was reconstructed with a homograph. The black open pore is a polyurethane foam that was directly applied to the area, and the negative pressure cartridge was applied over that. This is a big deal. So these guys can go really bad really quick. If they do not suction properly, these sponges will be popped open. You'll have a beep on your monitor that will let you know that there's a leak. These are easy leaks to fix. All you do is you literally get that sponge and press down to get that suction. And if it doesn't press down and it doesn't collapse on you and the patient doesn't go, right? Because that's the sound we want to hear. I know it sounds terrible. Then you need to find where that hole is. A lot of times it's in the corners of your dressing. All you need to do is grab a Tegaderm, throw a Tegaderm over 1/4 of it, wait for it to suction down. A lot of times it will suction down. If not, grab another Tegaderm, throw it over top of that one. Make sure that it is going over your line of demarcation from your past Tegaderm, because if you don't go over it, then you're just throwing another Band-Aid on top of a Band-Aid that's got a bullet wound. I mean, it's pointless. So make sure that, again, we're using the same common sense responses that we would normally use if it were our wound. So hyperbaric therapy. I've actually had an opportunity in my doctoral residency to do hyperbaric therapy. I did it with Avita a couple of years ago. It was more than a couple because I realized how old I am just now by saying that. And the cool thing about that is other than the fact that these guys' ears popped and every now and again there was a perf of the eardrum, these healing treatments were so much faster than the average person on a wound vac that you can watch a TV in the hyperbaric chamber. You constantly lose pressure as you're quote unquote descending or in the descendant into the hyperbaric therapy. It's highly oxygenated. It's hyperoxygenated. Your tissue perfuses so much better. Like, it was such a great experience. They usually watch a movie because it goes on for about an hour and a half to 2 hours. And they have little buttons to press if their ears are popping. They got a little soda in there that they can suck on to fix their ears from popping. It's just really cool if you ever get an opportunity to watch it. All right. I'm going to be honest with you. This drug therapy right here, if I have an opportunity to select this, I will select this because I need for you to know that this is a platelet-derived growth factor gel. To me, the word Regenex looks like Regenerex to me, which means regenerate, which means platelet-derived growth factor gel, if you can think of that. I don't really know how else to help you to remember this, but just remember the name of it if you can, or at least the first couple of letters. And then it might jog your memory as you see it on a test examination. Nutritional therapy, high fluid intake. Remember, these guys lose fluid. Diet high in protein. Obviously, protein is going to be our jam. Moderate fat, vitamins A, B, complex, and C. And then make sure that you have your enteral or parenteral feedings if needed. A lot of times these guys need that TPN to get a little bit healthier because when you're sick and you feel disgusting, you don't want to eat very much. I don't feel it necessary to continue to talk about hand hygiene. However, here we are, still talking about hand hygiene. Why? Because it doesn't happen and it's awful and I don't get it. We got 5,000 Sterilite machines at every 4 minutes of walking in any general direction. Take 3 steps, look to your left. There's a foam out right there. Use it. Wash your hands. Friction. Friction's our friend. Have lots of that, right? Sing your ABCs in your head. Do it backwards for all I care. Just wash your hands, please. I can't tell you how many times I've seen a urinal next to dressings while a person is doing a sterile dressing change, and then I scream, and then I end up in HR. But then I end up walking out of there with a smile on my face because I don't get in trouble, they do. So I say these things not to make fun, not to get people in trouble, because I don't want to get people in trouble. I don't want nurses to get in trouble because nurses get in trouble, they get yelled at, they leave, and then we're one more nurse down, and we're in a lot of trouble. And then we have bigger, more unhealthy ratios. So wash your hands, do all the things you need to do to make things good. You know what you need to do. And I don't even know how you could consciously do that and be cool with it. So keep your environment clean. No urinals next to dressings that you're about to stick on somebody. It sounds stupid, but I literally just did it last week. Less than 7 days ago. Yikes. Make sure you got your antibiotics in place, your bacitracin, whatever you're going to use. And then do a culture and sensitivity if something doesn't look good. If it's sticky and it's icky and the pus is green or some random color, you might want to go ahead and throw a Q-tip in it. Make sure it's sterile. Put it in a vial and close it up and throw a label on it. Put in a culture and sensitivity and send it out because that wound needs checked. A lot of times it's a MRSA or it's something that we need to have a specific antibiotic for, and Zosyn doesn't take care of everything despite popular belief. So keep an idea on it, okay? Keep an eye on it. Keep an idea what you're looking for, and remember the things that shouldn't happen in between. You should be fine. So, in a Western world, people don't like scars or disfigurement, to the point to where they would much rather have the wound than the scar, which makes no sense to me. So try to be sensitive to this idea of somebody caring about a scar. Where I come from, scars are beautiful because it means you've been through things. And if you've been through things, you're not a spring chicken. It means you have earned your keep in this world and earned your stripes. I would be more concerned with drainage and odor because that's indicative of what? Infection. Scars are indicative of something healing. So scars good, drainage and odor bad. If it's, got a nasty color to it. Be aware of your facial expressions while changing dressings. I can't tell you how many times new nurses will be freaked out when they take off a dressing. What I do in my head that works for me, and I don't know if this is going to work for you, is when I'm opening something up and I don't know what I'm getting myself into, I literally say my alphabets backwards in my head. Because I'm focusing so much on the ZYXWVUTSRQPO I'm not focusing on what's in front of me, and the fact that we all wear a mask still helps. So keep your eyes straight and glazed over if you can. If you do make a facial expression, apologize and say, oh my God, I wasn't expecting to see this. I'm so glad I'm looking at it right now because now I have a really good idea of why you're hurting so much. Throw it back at him. Go, oh my word, I'm so sorry. What you don't want to do is make the ooh or the freak out or make a comment about the smell. Like throw some incense or some oil or something onto your mask. If you know you're walking into a nasty wound, don't be that guy that's a jerk, because guess what? That's how these people don't go into the hospital, and they come in and their toes already fallen off. I've taken socks off and toes have come with it. And it's because they're so embarrassed that they're afraid of what the general population is going to say about it when they see it. And after you've been doing this for, I don't know, a billion years like I have, it won't bother you anymore. So the first year, I would say, just get mentally prepared before you walk in there, or talk to one of your techs, because 9 times out of 10, they've already seen it. All right, so now JP is ready to get the heck out of here. They've been moving around, they're getting stronger, they're feeling better, they want to go. So now we're going to start talking about patient teaching on wound care and discharge planning. All right, so patient teaching, teach them wound care, teach them dressing changes, make them do it in front of you before you discharge them. Make sure they get adequate rest, hydration, nutrition, and minimize stress, which is almost impossible for someone with a wound, but whatever. Tell them how to report signs and symptoms, right? I usually say pretty fast, if it stinks, if it's red, if you're feverish, get your tail back in before it's too late. So they understand what infection looks like. And understand what the bad things are. A lot of people, especially men, not picking on men, it just is what it is. They will do everything they can to try to fix it at home before it becomes such a big problem. They have to do other things, like come in, and by that time it's way worse than it could ever be. So I like this question, and if this question were a question I would have a choice of, I would pick it, just so you understand what that looks like. A basic principle of wound management for open wounds is to A, protect new granulation and epithelial tissue, B, apply topical antimicrobials to prevent wound infection, C, remove wound exudate with frequent dressing changes, or D, use occlusive dressings to prevent wound contamination. All right, first off, what's the best answer? Because all of those things are beautiful, but there's one that absolutely needs to happen, and I'm going to be really honest with you. Do I care so much about making sure that I've got antimicrobials that are topical on it? Nah, not really. I mean, they're there, but it doesn't mean it's going to be an absolute. Our biggest deal in this case, I believe our answer is going to be protecting new granulation and epithelial tissue, because that is going to promote further granulation of epithelial cells and tissue, which is going to then transcommunicate to other cells to do the same. And hey, guess what? I'm not going to get fired because I was right on that answer. Protecting granulation and epithelial tissue is what we need to focus on, because that's what matters in the world. And making sure that good tissue is good and the bad tissue is healing is the number one thing we're looking for. All right, the nurse cares for a patient with a clean wound that has formed granulation tissue, which, if selected by the nurse, would be the most appropriate for this patient. Allow the wound to dry by leaving it open to air. Apply an absorbent dressing to remove exudate. Debride the granulated tissue with the dry dressing, or keep the tissue moist with transparent film dressing. So let's see, allow the wound to dry by leaving it open. We don't want to do that because then it's going to dry up the nice moistened granulated tissue that is the good stuff, and we want the good stuff. So I would not leave that open to air. Apply an absorption dressing to remove exudate. Well, no, because if we have an absorbed dressing, then it's going to do the same thing. So if you notice with these questions, you got something that's going to dry it out, something that's going to dry it out as two answers. So knock those off real quick, because we want the granulated tissue to always be moistened so that it doesn't dry out and then have to crust over, be pulled off, and then start the whole process over again. So that's a no-no. Let's see, debride the granulation tissue with dry dressing. Debride? Why are we debriding? We can't do that. That's not a nursing thing. Nurses aren't allowed to debride. That's a doc or surgeon thing, right? So by default, the only thing we got left is D, which is keep the tissue moist, which makes sense to me, with a transparent film dressing. So let's see if we're right. All right, kiddos and kidettes, it looks like we have some competency in our brain. We want to keep it moist. So easy peasy lemon squeezy. And if you notice, those trigger words, two of them said to dry it out. And the third one said to do a procedure that we're not allowed to do. So by default, even if you don't know the answer, you came to it anyways. All right, so now we're going to move on to pressure injuries. And I'm going to try to get this done in the next 6 minutes because we have 115 slides. We're on 78 and we're at minute 114. So I think we've all had enough. Okay. Etiology and pathophysiology. So localized injuries usually happen as a result of a bony prominence. It usually is in a 90-year-old lady who has a BMI of less than 20. Make sure if they've got kyphosis or lordosis that you're putting a Mepilex on it, because you absolutely have to. It's an imperative. Most common sites, again, sacrum, heels, anything that's going to put a pressure area down. Make sure if you have heels, you need to float them with a pillow. If you can't do that, use waffle boots. If you can't do that, talk to PT. They always know how to get around that. But usually you'll have something that you can do to keep those heels off, or you can extend your heel around bed if you need to. So influencing factors, the amount of pressure, the intensity, the weight of the patient actually has something to do with it, believe it or not, because if I'm light as a feather yet stiff as a board and I'm putting 600 pounds down, it's going to obviously make a difference if I have a little old lady who's 5'2" and 98 pounds. Although she's not going to get a pressure injury that's going to be as deep as someone who's a lot heavier, trust me, if they're confused and it's midnight, they're going to be throwing arms at you. So make sure you're keeping an eye on that. Make sure that the tissue can tolerate the applied pressure given. So sometimes you have to soften the blow with a pillow if they have a hip that is a little suspect and a little red and is causing some issue. So make sure that you're not attaching the pillow itself to the patient. Make sure that there is some type of a cloth or a barrier, like a chuck pad, that is between the patient and the pillow so that we don't prevent an injury and then create one at the same time. When we're talking about exams, I'm absolutely going to put in an example of shear versus incontinent associated dermatitis versus pressure, because there's an absolute difference. Please understand what the difference is, and please understand that you need to know the difference so that we don't have to eat that cost as a hospital facility, and so that we're not saying something is that it isn't. Those ICD codes that dictate what the insurance is going to reimburse is absolutely going to be concomitant with what we say is wrong with the patient. So if you have a shear and you say that it's a result of someone laying in a certain position for an extended period of time, it's going to cause a lot of damage to you as a nurse and to all of your colleagues who have been working prior with that patient. All right, so another case study, 82-year-old woman has hypertension and limited mobility secondary to osteoarthritis, brought to the clinic by her daughter for routine evaluation of hypertensive treatment. So how is this going to appropriate with a disease process related to a pressure injury? And here we go with the classic. She lives alone, reports that she stays in bed or sits in her recliner throughout the day and watches, whatever on TV while she's snacking constantly. It's usually sugary foods that are processed, which is perfect for wound healing. Only it's not. That was a bad joke. All right, so she has little ambulation, which means she has little ambition, and a few position changes daily. So we're just asking for trouble. She's probably a really tiny gal that has hips that are protruding, and again, kyphosis lordosis. Whenever you're dealing with osteoarthritis, is a big problem. You usually get to about T5 or about C4. And that's when you have nice bony prominences, and then when you get to sacral region, you have some other issues. Make sure that while we're talking to these patients, we're educating them at the same time, because the second you start educating them, they're going to get sick and tired of hearing it. But after about, 150 times, they might actually pay attention. So please make sure that not only are you explaining these things to them, but you're showing empathy, because if you say it like I'm saying it in a monotone voice, it's just going to tick them off and they're going to leave, and you would have not been able to help them in any way. So please understand what this looks like. I'm going to absolutely, on your exam, if I have an opportunity, put it in this way. I'm going to use those trigger words. I'm going to say they're young or old. I'm going to say if they're malnourished or not. I'm going to say if they're fluid overloaded or if they're dehydrated. I'm going to say things like bony prominences. Please pay attention to the wording of the question. All right, pressure, injuries, risk factors, incontinence. Incontinence is absolutely going to help out. Any type of incontinent factor is going to get into the tissue. It's going to cause excoriation. It's going to cause it to be red. It's going to cause porous cellular changes, which is going to make the tissue even easier to break apart. Moisture, when you're dealing with skin and breaking, is always a bad thing. So make sure you have a nice dry area that is offloaded. Low pressure with diastole specifically. That makes perfect sense, because that's got to do with your ability to pump your heart effectively throughout the body. And if you have terrible circulation and deoxygenation to the skin, it's going to break apart easier. So that's simple. Mental deterioration, obviously that's going to cause a problem, because they're not going to know, hey, I've been sitting here for 5 hours and not moved. They won't know the difference because they are disoriented. Neurologic disorders, a lot of times if we have a TBI, we don't understand the same concept as having mental deterioration. Obesity, like we just talked about, the physics of 600 pounds offloading onto a body is different than 90 pounds, but it still can be affected in the same way if you don't offload that pressure, so make sure you're doing it. Pain is obviously going to be a problem, because if you're hurting, you don't want to move. A classic example is hip replacement patients that have an ORIF done, which is a procedure where they literally stick a nail in the ball and socket joint. It's very painful. It's very annoying. And you have to have an abductor pillow, which is also very painful for them. So once they get with therapy, they usually are cussing up one ear and down the other because they don't want to move, which is going to cause them to have a DVT, which is going to cause bigger issues. But first and foremost, they're going to have an injury that's related to pressure. Prolonged surgery is also going to cause pressure problems, because if you're sitting in one spot and guess what, you're on succinylcholine, you're not moving, so that's a big problem. And vascular disease, obviously if you have PVD, you're going to have poor healing and you're going to have easy breakage. All right, so a nurse talks to EA and her daughter about the activity at home. The nurse performs a thorough skin assessment and discovers, dun dun dun, we have something on our coccyx, 2 centimeters by 5 centimeters, shallow wound. So at that point, I'm going to get really, really close to it and see if it's tunneled, to see if I see any color up under it. A lot of times, a lot of these non-stageables will look like a regular wound, and then around it you'll have a line of demarcation, an approximation of what looks to be black or dark purple. If they're African American, they're going to be literal black, so keep an eye out for those. Make sure you're using your senses, like how does it smell? I know that sounds terrible, but guess what? We use our nose and we're good at it. So just get in the habit of doing those things. So now we're going to get into the tough stuff where we talk about stages of pressure areas 1 to 4 plus unstageable, deep tissue injury versus surface tissue, and also the National Pressure Injury Advisory Panel, or NPUAP, if you can remember that. So I feel like this is what we always see in a hospital setting. It usually comes from someone who's coming from an ECF. They usually have quote unquote altered mental status. and they usually have a reddened bottom like this. Now, why is this stage 1? Look at blanchability, because blanchable is going to be the one that dictates whether it's fine tissue and it just needs a little bit of, I don't know, orange top cream, or if it's going to need something more and it's going to need pressure reduction, and we're going to have to keep eye on it for wounds. Here's a stage 2, partial thickness. We've lost the dermis at this point. If you notice, there's some shiny yellow areas there. We're going to have open pink wound beds. Sometimes it's going to bleed. A lot of people freak out when you have wounds that bleed. I like bloody wounds because bloody wounds mean I have really good vascularization of the area, which means I have a chance of getting it healed faster. So don't let that be a proponent in thinking that this is going to be a poor healing wound, because it's not. It may be intact, it may be ruptured, it may be serosang, it might be filled with blister, it might be a blood blister, it might be a closed exudate blister. Like, there's a million things that can go on here. Just know that it's partial thickness loss of dermis. And that's going to be, again, the trigger words that you see, or you're going to see a bloody open with red pink or wound around the bed. This is a full thickness skin loss. We're subcutaneous tissue. May be visible, no bone, no tendons, no muscle at this point, but we are going to have what's called slough. So it's going to be kind of difficult sometimes to be able to tell what the depth of it is. This is why you need to go ahead and literally poke into it, as crazy as that sounds. These are the guys that tunnel and have tunneling pockets. So you'll literally grab your 4.5-inch Q-tip, you'll put it in, you'll feel resistance, and then you'll want to go ahead in a circular motion, because you'll find a pocket a lot of times, or a hole that you'll then dig further into. Your patient's not going to feel any of it. There's no nerve endings around it, so don't freak out. And then you'll be able to see exactly how deep you're dealing with, to see if you need to get a consult, if you're probably going to have to expect a wound vac. These are pretty nasty things, and they can either be really great or they can surprise you and be absolutely terrible. So make sure you're really getting into those guys. As much as you don't want to do it, you need to do it. Again, I haven't reviewed the slides, so here we are. May have undermining or tunneling. Wonder who just said that. So yeah, keep that in mind. Make sure that you know that if I have an opportunity to put that in a test, I will put that in a test. Because it's that important that you literally dig around, and I do mean dig, to try to find those pockets. All right, full thickness. We got muscle, bone, tendon, other supporting structures visible. May have eschar, may have slough. Osteomyelitis is a big problem, so you need to worry about your labs. We'll get into labs later. Don't freak out about it right this second. You guys already got enough to worry about. So keep in mind, I'm going to literally say bone deep. This is really important to me specifically because my stepsister died from this. She was born with spina bifida. I know you guys know this. I've said this before. She got a tear on her womb when they changed her brief one day when she was about 31 years old. She didn't know she had it because she couldn't feel it, and 3 months later she got septic, and when we discovered it, she was so bone deep that you could literally stick your fist through. So you need to really watch out for these guys, because these guys will not feel it. Sometimes, if you notice, there is some demarcation of what looks to be like hyperpigmentation of white. Guess what? That white is dead. That all needs to breed. That whole thing needs to breed. So basically, they wouldn't have a backside at all if I had my way in this world, because all of that is gone. Now you'll see where it gets a little bit lighter. That's probably the appropriate color. You'll see darker legs, but that's probably because of the flash. It was probably done by an old model Nikon that took that picture. So all of that white around that red is, if it's white and red, guess what? It's dead. That's how I remember that. So risk for osteomyelitis, keep that in mind. Make sure you understand the difference. I will absolutely make it very easy for you to understand, and so will the NCLEX. Okay, so remember, when you have instageable pressures, you need to get rid of the slough or eschar. You have to debride it. There's no way of getting around it. You're going to be at stage 3 or 4 at minimum, obviously. If you're on your heels, podiatry has to do that. Be aware, if you have a patient like this, it tells you they have a heel wound or a wound on their toes. Be really careful taking off those socks. A lot of times the physical toe will come off because it's necrotic. So be prepared. Just give yourself a little bit of grace and try to keep a straight face as best as you can. So this is that maroon localized area of discolored tissue that's filled with blood or a blister. This stuff is going to be a dark wound bed like we talked about earlier. It's going to have to be looked at a lot of times. It has to be debrided. All right, so what else do we need to worry about when we're gathering this? So we need to assess the wound. We need to appropriately diagnose it. I don't want to say the word diagnose because we're not docs. We need to make sure that we understand what we're looking at so that we can report it to the doc, who then will diagnose it formally. We need to make sure that we are servicing this patient so that we can keep pressure offloaded to make it worse. We don't want to do that, obviously. We want to make sure that they benefit from the education and knowing what they need to do so that when they're not around us anymore, they won't make it worse. We also need to educate them about resources like wound care and ostomy care. We need to let them know about home health because those guys a lot of times will need home health to do the dressing changes for them because it's too much for them or they can't get to it. Those are certain things that we're going to need to get into. And I think now that I'm thinking about it, if I have an opportunity to use that as a question, that will also be a question. And again, this is common sense stuff. If they've got a wound on their backside, they're going to need home health because they're not going to be able to do it. I'm going to expect you guys to know what the sign of an infection is when you're dealing with a pressure injury. You're going to need to know leukocytes, fever, increased wound size, odor, drainage, necrosis, induration, tunneling, etc., etc. So keep all these things in mind. You know what to expect when you're dealing with a wound. You've seen these things before. You guys got this. Alrighty. So complications. If you untreat it, you get cellulitis. That's a bad day. You can get a chronic infection where it doesn't heal. Also a bad day. Osteomyelitis. You're going to lose a limb. That's a bad, terrible thing, right? We're down to the bone, buddy. Possible death from sepsis. Most complicated complication or common complication is recurrence. So whenever we get this tissue and it heals back, sure, but it's always a little bit weaker tissue because the tissue is striated, right? It's changed its cellular form trying to scar over. Well, it's super duper easy because that tissue is very porous. So it's easy to re-break it open, especially if it's in an area where people sit and don't want to move. So it's important that we educate them and encourage them to move around a bit more and to have a little bit more autonomy and mindfulness of their movement every few hours. So, old Flo, she said if he has a bed sore, it's generally not the fault of the disease, but the fault of nursing. I don't necessarily agree with that because, well, the name of the game has changed in nursing since 1859. Sorry, Flo. So here's how this really works. Yes, we need to get RN, wound care, ostomy nurse, surgeons, dietitians, physical therapists, occupational therapists together. But what we also need is we need the patient to understand that their disease process is very serious and we've got to teach them how to care about themselves. Not care for themselves, but to care about themselves. And I know that's kind of silly, but a lot of these guys have given up hope. A lot of these guys are diabetics who were several hundred pounds, who are in very small chairs because they can't afford the nice lazy boys that recline, who have springs that are popped up because, again, they can't afford it because they're on a limited income and they get a stipend that isn't enough to sustain life. These are the realities of the things we deal with, and they can't move around a lot, so they can't get clean, and things get more infectious, yada, yada, yada. So make sure that we're trying to do our best with what we have in front of us and understand that there's going to be some margin of error that is going to fall on us as nurses. So we need to make sure we're doing our best to take care of that and make sure you're documenting it in your notes that the patient refused education, that the patient needed remodification of the education or needed recurrent education. I always say educated/re-educated. Patient still elects to refuse services. Make sure you're doing those things for legal reasons. Oh, friends, if I have an opportunity to make Braden Scale your answer for one of your questions, I absolutely and unequivocally will use this. You need to know your Braden scale. Braden scale is something that we use. It's a measurable tool. It lets us know what our pressure injury risk is. Auditors look at it. They will watch these guys if their Braden score is high enough. So make sure you are appropriately documenting these when you get to that section, because it's everything. So I want you to know Braden scale, assess pressure injury risk on admission. Got to do it at periodic intervals. Usually it's every 4 hours if you're on a progressive care unit. Do a thorough head to toe, identify those pressure injuries like we talked about. All right, if you want to get yourself in a lot of trouble, why don't you go ahead and give someone a stage 3 or 4 pressure injury after the admission, and make sure that you have a deep dive and an audit that turns into an SRE. You don't want to do this. It is a long, arduous process where they literally put you under a microscope and they critique everything you've done. And when I say they, I don't mean they, your nurse manager. I mean they, your nurse manager, they, director of nursing, they, the powers that be in administration that sit on the ivory tower with their clicky heels in the hallway when they bring coffee on Wednesdays because they are a hero. I'm talking about these guys who come in and are the president and CEO of the hospital, has to get into these, legal team gets involved, and hey, guess what? If you're lucky, you won't have to go to court, because if you do, then you're going to have a cross-examining lawyer who is also a doctor who is going to absolutely eat you alive. So make sure you are doing these pre-assessments, pre-admissions, and documenting these for this specific reason, like I have told you 4 or 5 times by now. As we talked about earlier, darker areas are going to be in darker skinned people. It's going to be purplish. It's going to be brownish. Every now and again, it's bluish. It's going to surround the skin. Make sure that you use a halogen light if you can, so that you can accurately assess it. Another thing that I do is I will get a light like your pen light. And if you literally touch the skin at a surrounding area and then literally turn it to your right just a few degrees, you will see it kind of light up as if you were checking fluid overload in scrotum. It's the same concept. So make sure that you've got the extra light on you. It's, part of what you're supposed to bring with you for the day. I see docs and surgeons use cell phones and the cell phone light that you have. I always ask my patient if I have to use that in a pinch. They don't care, right? Because it's not like we're taking pictures or snapping photos or anything silly. So make sure that you have a light on it, because it is going to make all the difference in the world. Sometimes if you have a little bit of darker skin, and that's okay. Additionally, assess the skin temperature using your hand. It may be warm initially and then it gets colder. And that again is because of the pathophysiological response. Yikes, guys, I am over talking. We got 10 more slides. Because of the response that their skin has based off of the amount of melanin they have in their skin. So make sure that you're watching out for that. Boggy or swollen tissue may indicate a stage 1 pressure injury. Oh boy, is that ever accurate. So if you got that boggy, I'm pushing a heel and it's mushy, that's a bad day. So you better watch out for those bad boys. Make sure that you're using protection. Make sure that they don't have any itchy sensation. If it's itchy and boggy, it's usually dead. Okay. Pain in the early stages of death. Once it's dead, there's nothing to feel. So see if they have any pain with that as well. Also be careful when you're poking it too, because your finger might go through it like it's an old watermelon. So just be aware, if you sit a cantaloupe out in the hot sun for 3 days and you stick your finger in it, it's going to go straight through the tissue of the skin. Not much of a difference if it's dying or it's decomposing. Okay, here we go again. Subjective data. Important health information, health history, medications, note any surgeries or other treatments, especially if an area has been cut open before because there's been an IND done or they've had to scoop all the bad stuff out, whatever the case may be. Also remember subjective versus objective data. I know it sounds silly. It's easy to forget. I always say, I object, and that's how I separate the two in my brain. So make sure that you understand which is which and how that appropriates to your assessment, because you don't want to have objective data in your health history or your medication remediation or your reconciliation. So functional health pattern assessments are a big deal, because if they're malnourished, their skin is going to be terrible. If they have incontinent issues and they are just kind of sitting in it, that's going to cause breakdown of tissue. If they aren't moving, that's a deal. And obviously, if they have a cognitive impairment, that's going to impair their ability to understand the concept of linear time as we understand it in this world. So make sure that you are hitting those key topics, because that's going to trigger doctors to understand that they need to put a little bit more thought process into this. And you giving them little hints and your demographic notes really, really helps out. All right. And then with your objective data, you want to make sure that you do a general synopsis. You want to make sure that you do one specific to integumentary assessment. And you want to also have your diagnostic assessment findings as well. All right, nursing diagnosis, everyone's favorite part, because we have to have a nursing diagnosis in order to go ahead and attach a care plan or education. So you want to make sure you're looking at impaired tissue integrity. That's a given. Risk for infection, that's also a given. I would also use potentially nutrition deficit would be another good one. Make sure your goals are attached to the appropriate nursing diagnosis. No deterioration of the wound, no infection, healing, have no recurrence. I would also put potential for education deficit due to dementia-related illness, if that's part of the application of your patient. Just make sure you're applying these principles and making sure that they are appropriate. So as nurses that are student nurses, you hate to hear evidence-based practice, one more time, evidence-based practice. As a nurse, while you were dealing with patients who are looking at you and going, "Hi, sweetie, what is it that you know?" And you go, "Well, actually, it's not what I know, it's what evidence-based practice knows." So you actually use it as arsenal. So make sure that you are educating these people using evidence-based practice. Make sure you are letting them know that there are studies by, Harvard, by Yale, by all the big guys that have done the evidence-based practice and have found the statistical data that is going to take care of them. A lot of times they don't understand that that's what we do. I think that they think we just hand pills to them some days, maybe ice water every now and again. Apparently the food being cold is also our fault. But we need to remind them that we are medical professionals who are capable of doing other things besides emptying a urinal. So make sure that you are giving them the actual facts of evidence-based practice and using it in your daily vocabulary. All right, so now we're at the end of our case study. EA is referred to social services for home health. We talked about that earlier. Home health aide scheduled to come 3 times a week to do dressing changes makes sense to me. A nurse will visit once a week to make sure medications and wound management has been taken care of. So they're going to check things like pressure offloading. They're going to look at their furniture, make sure that it's as comfortable as possible so that they don't have those hard spots where they would get tissue injury, and that they're not, picking their nose and digging into their wounds at the same time. Simple things that happens every day that you would never think. But that's why we need these people to come in and double check things. So when we deal with these very, very large patients, and that's usually what it is it's a larger patient who's non-compliant with their diabetes regimen, or it's the inverse and opposite, which is the little tiny 90-pound woman who has really gnarly lordosis and or kyphosis. Make sure that these guys have air cushions, that they have sand beds, that they have all the things. That's why all of our beds constantly move. You'll have a good patient who is a normal patient, maybe has exacerbative tonsillitis that needs surgical intervention. They're in their 20s and they're going to go, why is the bed always moving? Can you turn that off? And you're going to be like, no, I can't turn it off because that's what's for the other people who need to be in there with pressure issues. Every bed in every hospital in the nation, more than likely has these Hill-Rom beds that move to relieve pressure in certain areas. It's a constant vibration. You get used to it after about 12 hours, but until then you're constantly hearing complaining. And it's usually from, like I said, these younger patients who have nothing to worry about when it comes to wound problems. All right, so acute care for wounds and pressure injuries, pain management, control of other medical conditions, redistribution of pressure, possible surgery for debridement. And again, we are doing our pressure injury scale for healing. We're remembering our acronym PUSH, which is somewhere in the first 30 slides, I believe. Make sure you got your stage, your size, your location, exudate, type of wound, infection, tunneling, general status. Make sure that you have your digital images taken. A lot of times your wound and ostomy nurse will do that, so don't focus too much on that if you don't need to. And then, of course, the size and the depth. And again, relieve pressure. Don't turn the patient onto the skin with blanchable erythema. Don't massage acute inflammation. I can't tell you how many times this absolutely happens. Make sure that we protect damaged blood vessels, fragile skin. Don't ever pick up a patient by their hand or their forearm. If they have translucent skin, make sure you get them up under the arm. They're probably going to have a clicky glenohumeral joint because of osteoarthritis over years and years. Get over it. It's uncomfortable to feel that popping and clicking. Again, get over it because you're not ripping their skin off of their forearm, which is so easy to do. All right, once you get debrided tissue cleaned out and cleared out, make sure that you are absolutely avoiding cytotoxic cleansing agents unless it's infected. You don't want to irrigate something with Vanc if Vanc is caustic to perfectly good tissue. So just make sure that you understand where the good stuff is, where the bad stuff is. And honestly, this is important for you, but unless you're going to be a wound and ostomy nurse out of the gate, this is something that probably isn't going to be applicable for you right this second. All right, guys, we're almost done. All right, so wound heals over time. She also begins to increase her activity at home, which is great. What additional information should be taught to her and her daughter to prevent recurrence of pressure injury? We literally have said this 15 times. I don't know why we keep going over it. Yes, I do, because it's going to be a question on your test I'm more than positive about. So just make sure you understand the simple concept of pressure injury bad, pressure bad once healed. So period, point, paragraph. All right, patient and caregiver education to prevent recurrence. Early signs, let them know. Nutritional support, make sure they have good nutritional support. Care techniques if injury occurs, what not to do. Hey, guess what? Don't lay on it. It's that simple. And finally, evaluation expected outcomes. Patient with a pressure injury will have healed pressure injury or intact skin with no further breakdown. These are going to be included into our care plan. And that is it, guys. We got through 115 slides. It was 145 minutes. I pray that I never have to do one this long again. That was misery to go through and talk through. Thank you for dealing with screaming children. Thank you for dealing with the avocado guitar that randomly went off a couple of times and or any other bangs and booms in between. I will do this for all the other ones if this goes well and everyone likes it. I will make them much shorter because this is awful to go through and have to deal with it for this long, so I apologize. I did not know it was going to take this long. I know what to do different for next time, and I am not going to start over because this has taken me 4 hours to do 146 minutes, which was not my favorite thing to do. So I hope you guys listen, I hope you guys learn, and I will see you on the other side.